Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk, where we bring you the contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. I'm your host, Joel Berg. We're here today with Dr. Paul Casamassimo, who is Chief Policy Officer of the American Academy of Pediatric Dentistry. In the midst of this COVID-19 pandemic, we wanted to bring Paul in to answer some questions that are on all of our minds at the moment. So, Paul, thank you so much for taking your time to be with us to answer some questions that all of us have at the moment.
Sure, Joel. It's my pleasure to be here. I wish it was under different circumstances, but I'm glad to be here to try to help.
We're grateful that you have some information for us. So we're now all painfully aware of the extent and many of the implications of the COVID-19 pandemic here in the U.S. as it relates to pediatric dentistry. So can you tell us where our specialty is today?
Well, Joe, let me start by using that well-worn adage that we've all heard, and that is, give me a fish, I eat for a day, teach me to fish, and I eat for a lifetime. And as trite as it may be and overused, I think it's actually pretty relevant today for this particular crisis. And I would encourage our listeners, when we're all done, to kind of think back on what I just said, because this is such a changing, mutating type of environment that we're in that none of us has ever seen before, that what we should really do and be thinking of, as well as the content of things that every day we need to be taking on, is just a process. And the process is to look nationally, then look locally, act locally, and then act nationally, and I'll explain what those mean, and to do this every day, probably twice a day. And if you do that, you'll be in the best position in this time of misinformation and lack of clarity and everything else. So that's my message. Look nationally, then locally, and act locally, and then go back and look nationally again. So,
given that, Paul, how has APD leadership approached its response to this pandemic and advice to members?
Joel, despite what you may have seen or read on social media, the AAPD leadership has been meeting literally every day, sometimes twice a day, to keep abreast of changes and new information. When we get together and it's at a social distance on the phone, we discuss the next steps that people should be taking, and we try to balance fact and fiction. We're all in this. Everybody in the leadership in some capacity is being affected by this. And so we appreciate the anxiety and the frustration that members have looking for information. The other thing I want to say is that our staff at the national headquarters has been so active checking national, state, and professional websites and synthesizing data for us to mull over and then to transfer to our membership. Our slow, methodical, and I think thoughtful response really is to try to avoid getting misinformation out to people. What's true in California and New York may not be true in North Dakota. And so for us to try to be prescriptive really is not beneficial. The other thing that's happening is initially it was all about health and systemic health and prevention of or mitigating transmission. But now we started to move into some economic issues and the economic health of individual practices in our system. And so when you go to the AAPD website, you'll be seeing information there that we've been able to gather about how people should approach the economic consequences of this pandemic. Let me just say, I can't say this enough. People need to be in touch within their states and other members, sharing social media, keeping up with state and local recommendations, and make it a point to look at sources at least twice a day. For example, in Ohio, it was okay on a Friday to get your teeth checked and have your regular preventive visit, but by Monday you had to have a toothache and be in some pretty serious condition to see a dentist. So things have changed rapidly.
Which is pretty much where we are in the whole country at the moment. Ohio was one of the early adopters of that plan. So you mentioned the economic impact. What have been, and this may be an obvious question, but you're kind of getting a centralized view, what have been some of the biggest challenges for pediatric dentists in this crisis?
Well, I think the first one is just knowing what to do at any point in time. And it's like juggling. You have to know what to do today, but you have to be looking toward tomorrow. And I would say, as an optimist, we need to be looking at when we emerge out of this crisis and what to do. You know, this is new for all of us. I mean, I'm, a septuagenarian, and I missed both World War II and the Great Depression, which were the most recent challenges of this expansiveness that our country has seen. We really haven't seen anything like this before, so this is all new territory. The other challenge is just a confusion about what is a dental emergency. That's kind of the issue du jour right now. Should I see patients? Should I not see them? What really constitute an emergency? And what's the real risk to myself, to my staff, my family? So that's another question. And finally, this is all uncharted territory. And, when a dentist is diagnosed with cancer and has to make significant adjustments in his or her practice, for example, there's a lot of help out there. There's a lot of knowledge and background and previous experience. This is all new. And the helping hands that we would rely on in those situations is just not there. So there's a lot of uncertainty. So those are the biggest challenges I think that we faced with this crisis.
So you mentioned a list of challenges, which we're, I think, mostly aware of regarding the emergencies, because it's essentially universal across the country and around the world, likely, that we are essentially limited to children who might need emergency services. And I can only imagine with everybody home from school, with the kids jumping around and parents being teachers, perhaps not the best teachers, or the kids are going to fall, there are going to be some traumatic injuries, toothaches are going to occur. What are the considerations here when a child needs an emergency visit?
Well, this is probably the most perplexing problem at this particular point in time. And I would just say to members, there's no right answer here. This is such a complex issue. Some dentists have decided to close up shop totally, while others have said, I'm going to be here for emergencies, and so I need to understand what they are. The ADA and others have defined emergencies as pain, swelling, infection, and bleeding. And others have said this is an emergency, those things I just mentioned, but there are some urgencies, and then there's routine care. And I think at this point in time, on the 24th of March, 2020, we are saying only emergencies, only patients in that first set of categories that I talked about. The other part of this is the personal decision that a dentist needs to make. You have to balance the risk to yourself and your family and other staff members with the urgency of what is an emergent situation. A patient we might not have treated with antibiotics in this circumstance might be one that we do, because we just don't have the personal protective equipment or the physical layout to be able to handle that. The two challenges, I think, if you choose to see emergencies, is to try to identify as well as we can, and it's certainly not a perfect system, who may be infected with the virus. And then the second problem is dealing with any aerosol that you may generate in caring for a patient, who has an emergent situation. Some institutions are saying that if a patient is not infected, so you've given them a questionnaire, maybe they've been tested, you've taken their temperature, you're comfortable that they're not infected, you can go ahead and treat them, and you can treat them with basic PPE, personal protective equipment, and not need a special mask. If the patient has symptoms or is known to be infected, they're probably better seen in a medical center, and you don't have to have any hesitation about not seeing that patient dentally and getting them to a center where they can be taken care of. If you're using a procedure on a patient you feel is not infected and is generating an aerosol, people are saying probably use an N95 mask or a so-called ventilator mask if you have them. That even with that, there's some potential that an aerosol might not be controlled. So that is the ultimate in self-protection, is a non-infected patient generating an aerosol and you having appropriate protective equipment to be able to mitigate or minimize the infection. And not every dentist has those. So again, while what I say may be confusing, you really have to size up your own practice, your own risk level, your ability to use PPE in an appropriate fashion, and whether or not you generate an aerosol. One of the ethical dilemmas we'll look back on is we will probably be extracting some teeth that we, under certain circumstances prior to this pandemic, would have tried to save.
Yes,
and,
that's clear.
That's the challenge.
So speaking of hospital centers for emergencies, many of our perhaps in the past what we would have deemed emergencies are children in a lot of pain, perhaps with severe early childhood caries, and we've scheduled to provide treatment under general anesthesia in a hospital operating room. And for a variety of reasons, those cases are being denied or triaged, understandably. Can you talk a little about what's happening here nationwide regarding the use of hospitals or operating rooms?
Sure. I think at this point in time, every medical facility across the country has canceled elective surgeries, both in medicine and dentistry. So if you have a patient who's not in pain but needs extensive restoration but has no symptomatology, that case probably should be looked at very closely as to whether or not it needs to be done. And the challenge there is that it's two-sided. If you don't treat that patient and they have pretty severe early childhood caries, they may blow up and become the patient who needs to be treated at some point in time. If you treat them, on the other hand, and take them in and they've been asymptomatic, you're using up PPE, you may be using OR time that could be needed for other patients, and there's a potential for post-operative hospitalization, small as it may be, that could take a bed that would be needed to manage a patient with a corona infection. So there's all of these questions that we have never been challenged with before. And so the bottom line, I think, at this point is if you have an asymptomatic patient, irrespective of the amount of tooth decay, you can't crystal ball and say they'll have a blow up in a week or 2 weeks. You need to defer the procedure. And if you have a patient in pain, you certainly can take them, or a cellulitis, you could take them to the operating room and treat them. And most hospitals will require you to use aerosol mitigating PPE. So that means a ventilator type of mask and other types of procedures. So I think that pretty much summarizes it. Talk to families. Talk to the anesthesiologist, talk to your OR team before you make that decision.
The challenge is going to be the ones that are in significant pain and a high risk of subsequent infection. But as you said, we have to manage them individually and locally. You've touched, Paul, on the economic effects of the pandemic, which are being felt significantly already by practitioners. We probably have not seen the last of the fallout. So can you tell us more about what is happening around the country where routine pediatric dental care has been curtailed by government fiat, essentially?
Well, this is the most rapidly changing aspect of this epidemic because people are feeling it. People are hurting, and they're having to make decisions about letting staff go and whether they will continue to pay staff. There's no money coming in, and so it's really a complex problem, and it really is very geographical in nature. If you look at the social media and the chat lines that we have, you can see that dentists are being very creative and they're being very heroic by keeping on staff, cutting back on physical presence of staff in their offices, yet maintaining their pay. And so we're seeing a whole variety of different approaches. My suggestion, and again, it's a very generic one, is look at what's happening in your state, see what your colleagues are doing. Many have had the opportunity or the foresight to consult with attorneys and CPAs and unemployment authorities in their locale to try to determine the best possible outcome of the economic downturn that we all will have already begun to see. So rather than try and be prescriptive about what you, Joel Berg or Paul Casamassimo, should be doing, I would say try to find information locally and see what other members of your professional community are doing and what your professional advisors suggest you do. A couple little anecdotes. Dentists in Ohio are saying they're having trouble getting through to the Small Business Administration to ask about loans and those kinds of things. And I think it's just one of these volume kinds of issues because everybody's trying to get information. And the other thing I've heard is that the best sources of information appear to be colleagues, people who have had the foresight to get involved in the economic issues early on. So I'll stop there.
Yeah, no, that's helpful. Going forward, we see a lot of advice about social contact, financial survival, health, keeping our optimism in the midst of uncertainty. So how would you advise our membership to go day by day to be in the best position for the future? There are opportunities, and I want to hear what you've thought of in this regard.
Well, I think the follow the information, keep checking regularly, talk to your colleagues. Again, I keep the mantra is look nationally, then locally, and act locally. And right now, there are some efforts in Congress to make sure that the dental community is not left out of recovery packages that are being looked at. So I would encourage everyone, if they can, participate and talk to their legislators about conveying to them that these are small businesses that are vital to the health of their constituencies, and so they need to be thinking about the long-term survival of them.
So, Paul, the crisis has brought some issues in our system forward and brought attention to others that we knew were there, but maybe we didn't address well enough as a dental care system. So can you speculate on what some of those are and what we should do to take them off the table in the event of another epidemic in the future?
You know, this has been the one perhaps opportunity in this crisis is to be able to step back and look at the things that we should have prepared for, and then some of the inequities in our system that kind of have always been there but have never really been something that we've had to deal with. So there's a couple of them that I want to talk about. The one is many people listening to this will be aware of the auditing that's gone on in Nebraska about pediatric dentists being asked to pay back money for doing treatment that is recommended by the Academy, and that is putting stainless steel crowns on primary teeth in high caries risk children. And the Medicaid argument is it's not the least expensive treatment, meaning that you can do tooth retained restorations, composites, and things rather than crowns. And we all know that in those kids, eventually those restorations are going to fail. And so it's really, I think, an opportunity for us to say, we've got this group of kids, and if we treated them the way that the Medicaid rules were set up, we would have this increasingly large group of kids with the potential to have dental emergencies in another crisis. They're just time bombs ticking out there.
Clearly, yeah. I think we're seeing that a lot. And it's not just stainless steel crowns, it's a lot of other aspects of what we do routinely and what we've been talking about.
And the other one, Joel, is this a study that we're currently doing in the Policy Center. Almost in every state, pediatric dentists have been denied access to operating rooms in their hospitals. And there's a lot of reasons for that. We're trying to understand why that is. But again, this is creating this huge population of young children with untreated disease who have to wait months to be treated, and sometimes years to be treated, and maybe never get treated and become dental emergencies, facial swelling, unremitting pain, overdose with acetaminophen and liver damage. And so that's a problem, and nobody, except for the pediatric dentists, have really been concerned about it. But in this epidemic, we've got this population of kids who, again, are ticking time bombs because of issues related to them not being treated or able to be treated in operating rooms in our country's hospitals. And so we'll have more about that coming out soon. But
it's really about, Paul, would you say it's about demonstrating the medical necessity of these treatments that we've been talking about for so long, and this situation brings that to forefront?
Well, some people have said, well, dentistry has been diminished because of this epidemic, because of the life-threatening aspects of it. And I say, no, it hasn't. I said, we have now created an awareness in the general population that dental problems can be life-threatening and need to be dealt with within an epidemic like this. I think we're in much better position to argue for the importance of oral health, and particularly to get kids into offices and seen by pediatricians for oral health far earlier than has been typical. If we could go into our next epidemic, God forbid, and have a population of kids who are all dentally healthy and caries free, that would be one thing we could take off our table.
I agree with you completely, and I think all of us understand that approaching this by demonstrating the medical necessity of the treatments to prevent these emergencies, but also the prevention that we've espoused for decades, is going to become more prominent. So, Paul, a last question for our audience. Finally, in all crises, heroes emerge, and acts of goodness and sacrifice come to the forefront in places that maybe we never expected. Have you heard about any things that you can leave us with so we can be reassured about the future?
Well, I think the fact that we're all coming together. I was on a phone call. I'll give you two examples. I was on a phone call with the pediatric dentists in Oklahoma, and they were all telling stories about the things they were doing for their patients and their staff, going to what I would call economic and personal risk extremes to get both those groups taken care of and to keep them healthy fiscally and dentally and systemically. I mean, I was almost in tears listening to that. The other is a situation of a pediatric dentist that I think most of us who've been around a while know, and he and his partner are continuing to pay his staff. They're seeing emergencies in their office. They're letting their staff be at home. They're continuing to maintain their salaries, and they are even talking about taking out loans to get through this crisis, to keep their staff on board. And I think those kinds of stories are just heartwarming, that we have the kinds of people we do in our specialty who are willing to do this kind of thing for their patients and their staff. It's just pretty amazing when you think about it.
Yeah, I think, after this, what I might describe as a forest fire, we're going to see a new sprouts form, and they will bring things perhaps we never expected, many for the better. And I think you're a former CODA commissioner. I'm currently following in your footsteps, and a lot of things are going to happen in the urgent mode now and in the future in terms of how we educate towards all the things that you just talked about, Paul.
Joel, that's absolutely true. CODA does a good job, and they're very conservative, but we now know we're going to have students graduating who will not be able to go into practice because of this situation. We have young practitioners whose practices are going to go belly up because they've got student loans. We've got to fix that. We also have to be able to put dentists into practice with less time-oriented requirements. Let them demonstrate their ability to practice pediatric dentistry. Don't tie it to a calendar. And same thing with our examination community. Let's figure out a way that we don't have to set up these convoluted, patient-oriented examinations. Let's figure out a way to test the quality.
We've got the OSCE. We've got other things that are in place already. We can go to those immediately.
Absolutely. And so hopefully our profession, the practicing profession, organized dentistry, and the educational community will hear these things and say, let's not go through this again. Let's figure out how we can be ready should we have another epidemic like this.
And I got to ask you one more thing. I think one of the system changes that we'll see is regarding the push for prevention is the whole compensation system, which currently pretty much only rewards procedural things, I think is going to go into sort of medical management mode quickly so that we can actually be rewarded, compensated for the really important efforts we take in terms of educating people about what they can do at home to improve their oral health.
Absolutely. And, the other part of this, Joel, is we talk about value-based care. We are the perfect specialty. We can get young kids who have mouths full of decay. We can fix it, remove the infection, and get them on a regular course of prevention within our practice. So we should be the poster children of a new system where we have fee for service to get kids into good situations and good oral health, and then some kind of capitated system to keep them there throughout their childhood. I think we should be ready to look at something like that when this crisis abates.
Paul, thank you so much for taking your time to talk to us today. Paul is the Chief Policy Officer of the American Academy of Pediatric Dentistry, and we're all in this together. That's the common thread of what I've heard today, and we're all going to survive it and excel together when we're through. Thank you so much, and thank you for tuning in to Pedo Teeth Talk, where we bring you contemporary issues important to you and your practice. Brought to you by the American Academy of Pediatric Dentistry. I'll talk to you again real soon.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.